Welcome to the Wow MD podcast, where in each episode, you will get in 30 minutes or less valuable pearls about holistic wellness, anti-aging, hormone therapies, beauty trends, and other facts you should know about our medical healthcare system and your health that no one is telling you. My name is Dr. Mirala Chernayanu. I am a conventional board-certified OBGYN physician who, after the loss of my father due to a careless and uncaring medical team, decided to retrain and seek certification in anti-aging and restorative therapies. What I know, I am happy to share with you. Thank you for tuning back in, and I welcome you to another episode of the Wellness Optimizing Warrior MD podcast. I ended the last week's podcast episode with a very simple question. Why don't we know more about this topic of optimal testosterone levels, especially since testosterone therapy is used for women and it seems to have gained a lot of popularity in the last 10 years? The truth is, many people agree that researching women's health is significantly underfunded. And it's a big problem because there's not enough funds and not enough interest to dedicate time and money and resources for researching wellness, women's health issues. Let me give you a few examples on how this is important and pertaining to what we're talking about here. Let's take the example of diabetes. The prevalence of diabetes is 11.6%, which is the percentage rate at which you're going to find diabetes in the general population. So about 1 in 10 people is diabetic. In 2021, NIH, the National Institute of Health, spent $1.1 billion specifically on diabetes research. So obviously, where do I get these numbers? Google AI. And according to Google AI, in 2023, NIH spent $29 million on researching endometriosis, which is an extremely debilitating condition estimated to affect 12% of women. Same prevalence as diabetes, maybe a little bit more. But look at 1.1 billion research funds versus 29 million. Now, the cost burden of diabetes per patient per year is estimated to be anywhere between $3,000 and $18,000. Depends on how severe the diabetes is, the age, and so on and so forth. And here's the thing, the cost burden of endometriosis averages $12,000 estimated. But if you add the lost work days as well as the decreased performance at work due to the pain from endometriosis, it could cost the economy about $16,000 or more per patient per year. So as much as diabetes. So this extremely debilitating complex condition that we should strive to know more about is assigned a fraction of the funds dedicated to diabetes, even though the cost burden is the same, if not worse, for endometriosis. Now, here's the problem. Endometriosis, which again can be extremely debilitating for many women, is not studied to the extent that it should be studied, even when it is studied. And the treatments that could help women restore their quality of life and live a life that is not full of pain are not studied because all the research that would go there is underfunded. So money is not spent on this specific chapter in women's health because, listen to this, you're going to love this reason. Pain during a woman's period has been accepted as the norm. And young women are being told period pain is normal. In case you didn't know, just as a quick recap, endometriosis is an inflammatory development of the endometrium outside of the uterine cavity, on top of the uterus, on top of the tubes, on top of the ovaries, on top of the lining that covers the uterus called peritoneum, inside the uterine muscle. It's a very annoying condition, and basically the lining of the uterus, which bleeds every month when time comes for a period, will bleed wherever it develops and will cause a lot of inflammation, and the bowel gets stuck to the uterus and the ovary gets stuck to the uterus, and it's very painful to have sex. It's very painful when you have periods. It's painful when you ovulate. These women live in pain. And unfortunately, young women are being told pain is normal. Just put up with it. You're a woman. Public awareness of this condition is very limited. 9 times out of 10, when I mention, hey, you might have endometriosis, the woman in question has never heard of this. 9 out of 10. No one seems to care that, coming back to my topic, that testosterone is an estrogen antagonistic hormone, which is the opposite of estrogen, antagonistic. And why does it matter? Because endometriosis is considered an estrogen-dominant condition. It's related to estrogen. Every single treatment for endometriosis works as long as you lower the estrogen in the woman. So I'm going to ask a question that many smart doctors have already asked, and they already know the answer. Why not use testosterone for endometriosis? Years back, we had danazol, a synthetic steroid that was used to treat endometriosis and was very effective, would take away the pain, but its use was discontinued. It had too many side effects, but it worked by decreasing the estrogen levels a lot and having a very weak androgenic effect. Now, testosterone is a natural hormone. It does not decrease estrogen levels. And many women have excellent tolerance to moderately supraphysiologic levels, like I just talked about in the last 2 episodes. It improves pain levels for endometriosis and allows for significant improved quality of life for women with endometriosis. But again, there seems to be zero interest to explore this avenue of treating endometriosis. Why? Your answer is as good as mine. Another reason why research is minimally available for endometriosis is because, listen to this, you're going to love this, this condition is considered benign and not life-threatening. So basically, you can live a full life expectancy all the way to 80 with endometriosis. Once you go through menopause, yes, things are going to get better. It's not going to kill you. And who cares if it costs billions of dollars in lost productivity? According to some entities, we actually could be losing 80 to 120 billions of dollars of economic burden due to endometriosis. You compare that to about 130 billions from hypertension. That's about the same, right? 120, 130 for hypertension, 200 billions or so for economic burden caused by cancer, 300 to 400 billions caused by diabetes. So yes, it is true. Cancer, heart disease, hypertension, diabetes are killers. Endometriosis is not a killer. Life expectancy is not impacted. Only the woman's quality of life, which makes people who are not interested in funding research for this debilitating condition not look very good. But it is what it is. We don't have any control over it. Same with menopause. It is inevitable. It is accepted as an evolutionary consequence of the human body. It is an inevitable consequence of aging ovaries. It's something that women have to put up with. Even though they're not in menopause as a phase, they will experience menopause and postmenopause for the entire duration of almost the second half of their life. And it could be very gnarly and very, very, very nasty for many, if not the great majority of women, because it will change everything. Now, there is minimal interest from government entities or large groups to sponsor research into menopause and specifically into hormone replacement therapy. Listen to this. NIH allocated $56 million for research regarding menopause in 2023. And in 2024, again, according to Google AI, so hopefully the facts are correct, there was a whooping $2 million increase in this budget. I don't know how much research you can do for $2 million extra, but again, I'm not going to get into the whole NIH, the WHI study with the estrogen and how damaging and misleading the results of that study have been. I do want to stay on the focus, and the focus is why is there not enough research around the topic of menopause hormones, testosterone, and give you some pearls about testosterone. What's interesting and what you should know, because women think, oh, there should be testosterone available for women. Well, no big pharma company has been willing to put forth a product that is a testosterone product specifically formulated for women. I don't know why, because testosterone works and it's awesome. There's plenty of data, and there are studies that are smaller in the sense that they do not have large number of patients enrolled, like tens of thousands. These studies are done on a very small scale. However, there's a lot of research available. Many entities that are bigger regulatory entities simply choose to ignore the science, the research, and label it experimental. So not approved. So if you wonder why we don't have more studies into what would be an optimal testosterone level, and that goes for estrogen and progesterone as well, especially when we replace testosterone in women, well, that's why. What's extremely interesting is that the only approved medical indication for testosterone therapy in women is to treat female sexual desire dysfunction, also known as female sexual arousal disorder. So to add insult to injury, the medical governing bodies that are regulatory or established standard of care for physicians, as far as hormone practices, simply look at testosterone therapy for women from the viewpoint of addressing sexual dysfunction, specifically sexual dysfunction related to low sexual desire. It does not seem to be of interest to anyone that testosterone therapy could possibly improve severe and moderate migraine headaches in many women. I'm not saying in all women, but in many women, it can actually improve their headaches and keep migraines at bay. It does not seem to be of any interest to anyone as far as the governing regulatory bodies that set standard of care for hormone therapy and assign funding that testosterone is the most powerful anabolic hormone that can help treat lack of motivation, fatigue, loss of stamina and endurance, and loss of muscle mass as women age. It could be the best treatment we have for frailty syndrome, a geriatric condition characterized by a decline in multiple physiological systems, making older adults very vulnerable to adverse health outcomes like a hip fracture and specifically slow death. It is a collection of signs and symptoms that includes weakness, reduced grip strength, as well as slow and very decreased ability for any physical activity, with the general sense of fatigue and exhaustion, losing weight without trying, and more importantly, losing muscle, leading to sarcopenia. It is literally, the frailty syndrome, it's literally a state of increased vulnerability to stressors, leading to a much higher risk of falls, disability, hospitalization, and even death. Obviously, frailty is not to be mistaken for aging because it's a very significantly increased state of vulnerability beyond simply expected changes due to aging. Now, we do know that low testosterone causes a decrease in muscle mass, so the body's ability to burn calories. You have less muscle, you burn calories a lot less than usual. So you have an increased propensity to accumulate stubborn belly fat with low testosterone. And without optimal testosterone levels, a woman will be more fatigued, more unmotivated to exercise, which further reduces her activity level, which will promote more weight gain. So it is natural to ask, wait a minute, if testosterone can do all these things for our metabolism and muscle and motivation, then can we use testosterone to lose weight? Well, many women have done it successfully, and they have lost anywhere from 20 to 40 pounds. They feel more in shape than they've ever been when they were younger, thanks to testosterone. It's not applicable to everyone. That's the thing with hormones, right? And that's the thing with weight gain. Weight gain and weight management is very complicated, but when weight gain is the result of inactivity, fatigue, loss of stamina and endurance, loss of motivation, all of it leading to loss of muscle mass with a change in the body composition characterized by increased fat, this specific situation can probably be easily reversed with testosterone therapy and successfully so. Now, here's another thing no one talks about. No one talks about how testosterone therapy can be extremely useful to strengthen and improve bone density. Women are instead given biologic agents that increase the risk of cancer and strengthen their bones by interfering with the natural turnover of the bone. This natural turnover of the bone allows bad bone to be destroyed, which unfortunately by using these medications, these biologic agents, we could possibly lead to an unhealthy bone composition and increase the risk of fracture. And all of these have a warning label, hey, your bone density might look better, but you have an increased risk of fracture. Some women are offered anabolic agents, new ones on the market like Tymlos. This drug carries a risk of osteosarcoma, which is bone cancer, and has a black box warning from the FDA. In case this is the first time you hear what a black box warning means, it indicates the medication carries serious risks, including increased risk of death or very serious injury. It is assigned to the medication to alert the healthcare providers and patients about that using this type of medication can lead to life-threatening adverse events. It is literally the worst designation a drug can receive before it's likely going to be eventually banned completely and pulled off the market. Again, it means it carries a significant risk that might outweigh the benefits, and the use of this product should only be used with extreme caution and only after other means of treatment have been exhausted and are not suitable for the patient. That is all that the black box warning means. So why in God's name one of my patients walks into my office with a fracture. They had a bone density and they found some osteoporosis. And the orthopedic doctor, instead of saying, hey, go talk to your gynecologist, you're going to need some hormones. They're great. They're anabolic hormones. They might help with other things. Is telling her, well, we got to get you on this drug, Evenity, but your insurance is not covering it. So why don't you take Timlos instead? Testosterone has not killed anyone and is not going to give anyone cancer. On the contrary, there are doctors using testosterone to treat advanced breast cancer with high-dose testosterone therapy. So why not, this is my question for you, why not use a powerful anabolic hormone that can improve a woman's mood, her stamina, her endurance, her muscle mass, help her self-esteem and sexual function while helping restore her bone mass? Well, no study has been aimed to look at exposing women to different types of testosterone and different dosing, measuring the levels, and then correlating what levels will work best to improve and restore bone mass. No studies that I'm aware of exist. If you find one, please hit me up with that information. I really would like to know it. Now, I can do a whole topic of bone health after menopause. I don't want to diverge. I'll come back with this in the future in another podcast episode. I just want to focus on why we lack scientific data about women's health and specifically about hormones. This is a very sore spot and a major weakness in today's medicine, women's health research. And many experts agree that women's health is just not a topic of priority for medical research. So I discussed a little bit of why women's research is lacking. Actually, I discussed that it is lacking. I didn't discuss why it's lacking. But did you know that in 1977, an FDA policy recommended excluding women of childbearing potential from all phase 1 and early phase 2 drug trials? Now, this policy was very broad and literally recommended excluding not just women who could possibly get pregnant, but even women who used contraception at the time, who were single, weren't having sex, whose husbands were vasectomized, which means they couldn't have kids anyway. And it literally was a consequence of the very tragic results of the thalidomide study, which included pregnant women. So obviously, there was a study. This thalidomide was a very widely used sedative in Europe and Canada. Thousands of women who took it gave birth to babies with horrible limb deformities. So the FDA panicked and said, oh, shoot, we're going to eliminate all women from any trials because we don't know if we're going to have malformations. So again, it was an overreaction. Just like the WHI study that said all hormones are bad was an overreaction, right? So after this thalidomide study, all women were banned from participating in clinical trials for medication until 1993, when it took an act of Congress to write the inclusion of women in clinical research as a law, as a federal law. So think about this. Why am I bringing this up? I have a point, I promise you. Think about this. As a woman, you might be given or prescribed a medication that has never been studied in women, only in men. Your cardiologist or your primary care doctor or your internist will dose your statin the same as he would for a man, even though there's a study that highlighted clearly that for 86 FDA-approved medications, there is enough evidence to show that there's a significant drug dose gender gap, with women experiencing stronger side effects than men in 90% of the cases. So we know that the same drug given to a woman and a man will be experienced differently with a higher chance of side effects for a woman. We know that. But did you know that the statins were FDA approved in 1987 and not studied in women? Did you know that Prozac, Zoloft, Paxil, and Effexor, this is just a few of the major antidepressants that are prescribed daily in women, were FDA approved before 1993, therefore not studied in women? These are just two examples. I guess you can look up your medication and see when it was FDA approved, which means that if it was FDA approved before 1993, it was not studied in women. So, unfortunately, for many years, medications were tested in regards to only the male body. Having female research participants was not required for funding from any major institutions until 1993. This unfortunately left women out of the history of medicine and research in very drastic and very impactful ways. And the implication of this exclusion are enormous because many medications created and approved before this benchmark date, 1993, are still on the shelves today and are commonly taken and prescribed to the American population, to the American female population, with no clue of what they do to a female body in the dose that has been studied and approved for a male body. Hello, do we need some new studies or what? Now, I don't want to veer too much off topic, but consider the fact that there is such extraordinary bias around research that involves women, and so much more bias on research surrounding hormone therapy for women. So, how do we keep it real? As long as your doctor has received additional education from a reputable forum which provides training in hormone therapy, then he or she will be informed with the best information available and with the most up-to-date research. So don't just show up in a doctor's office and say, hey, I need some hormones. You should ask, what are your qualifications? How did you get your qualifications and what is your experience? Ask a little bit, right? Your regular doctor, your primary care doctor, your internal medicine doctor are most likely not informed. And unless they're specifically trained in hormone therapy, they will just repeat to you what they heard 10, 15, 20 years ago, maybe recently in residency training, that all hormones are bad for you and give you cancer and you should stay away from them. Now, these statements have been debunked, refuted by much research that came along in the past 20 years. But unfortunately, estrogen has been painted in the medical community's opinion as a very dangerous hormone. And guess what? Testosterone has been dragged right alongside it, though it is a very different hormone with minimal research focusing on testosterone benefits only for sexual dysfunction. So along the same lines of what I was saying before, I was talking about how no one focuses on the benefits of testosterone other than, hey, it can improve a woman's sexual desire. I would like to point out to you the fact that testosterone is a major influencer for a woman's brain and mental health. How? Well, hello, this is how it impacts sexual desire. It impacts a woman's brain. This is where sexual desire comes from, the brain. If it is powerful enough to positively impact a woman's sexual desire, believe me, it is powerful enough to impact a woman's mood. Plus, positive mood is intimately tied and needed in order to desire sexual intimacy. How many grumpy women do you know that are super horny? I don't know of any, but if you know of any, that's an exception. A depressed and sad woman will not feel excited about having sex. Plus, the medications that she will be on will take away that sex drive completely. So let me ask you a simple question. Are you or do you live with someone who is a woman who can be very moody, easily irritable, easily frustrated, highly emotional, depressed, or anxious? What if instead of immediately labeling her as a depressed woman and starting her on an antidepressant, we test her testosterone levels? What if instead of sending her to a psychiatrist, we test her testosterone levels? And what if testosterone hormone therapy is proposed as a trial of 4 to 6 months to assess the impact of testosterone therapy on her mood? Well, if you've listened to me talk before and you watch me on social media, you know my opinion about this. A lot more marriages would be saved. There will be a lot more happy women in the world and many happier families. Why? Testosterone is a hormone with major antidepressant qualities. It is a mood stabilizer. You know, the women whose mood are up and down, they would greatly benefit from a trial of testosterone therapy. Now, it's not going to change your mood in 1 week, 2 weeks, or 3 weeks. You will need the consistent exposure. Just like an antidepressant, the brain needs some time to rewire your pathways. The hormone needs to influence your neurotransmitters. So you got to give it a little bit of time. There are women who come in and they're like, oh my God, I feel amazing. And it's a month later. But not everybody's that way. Now, here is the question. And you might already be asking that, like, come on, lady, you're talking about all these things, but what about the testosterone level? What would be the optimal level of testosterone that would lead to an antidepressant effect? What would be the optimal testosterone level that would cause enhanced sexual desire in a woman? Would it be the same as the antidepressant effect? What would be the optimal testosterone level that would improve osteoporosis and restore bone health? What would be the optimum level of testosterone that is safe for long-term use to improve loss of muscle mass, loss of stamina and endurance, to improve frailty syndrome of aging, and allow extending functionality well into our 80s and beyond? Well, we simply do not know, because no one is studying the answer to these questions. So if you're out there with your doctor doing testosterone therapy, you're a trailblazer. So there's not enough research. There's not enough evidence. There's not enough data. We don't know. That will be the answer. Now, I can share with you my own personal opinion about optimal testosterone levels based on what I was told during my training and based on my observations and based on my experience with thousands of women. Optimal testosterone levels for a woman can be anywhere between 50 and 200. So yes, it is a very wide range because each woman is a unique, individual, biological human entity, and each woman has unique individual needs. Therefore, each woman will have an individual, unique response to hormone therapy, including testosterone. So that makes research even more complicated and difficult, and also makes research more limited and expensive, which brings more value to the smaller observational studies that are more boots on the ground, involving real-life cases and real-life experiences. Now, it would be very interesting to know if the testosterone level required to improve bone mass is the same or needs to be higher to improve sexual desire in a woman. Maybe we need an even higher level to achieve the antidepressant effect. We don't know. But maybe we just need lower levels, like 100 and just a little bit above 100 if we're going to just improve muscle mass, stamina, endurance, the frailty syndrome of aging. Well, if you're hoping I have the answer, again, I don't have an expert research proven studied answer because no one has looked at this. This has not been studied. There's enough difficulty getting doctors and researchers to accept that testosterone therapy should be used for women for any other reason than improving their sexual desire. Hello, women are so much more than a sexual partner to a man. Women are men's equal in this world, and the human race will be extinct without us. Women's health, and especially hormonal health, is a subject of research that is viewed upon with distrust and suspicion. Why? Because the public opinion has branded all sex hormones as dangerous. Okay, hello again. Sex hormones are dangerous? We wouldn't reproduce and have babies and continue on as a human race without our sex hormones. Just because we call them sex hormones does not mean that is all they do. We should name them anabolic youth hormones because that is what they really are. They are anabolic. They repair, they help regrow and restore health. As long as we have our sex hormones, we feel good and we look good. When our sex hormones are gone or they decline, we lose our vigor and youth and we start to age. So just a few pearls about testosterone therapy and maybe hormone therapy in general as I'm approaching the end of the podcast. There is an art to hormone therapy management. Talking and listening to a woman's clinical response to hormone therapy and integrating all of that with the hormone levels, taking into account what type of therapy she's using, when the levels for that hormone are tested, is all part of the picture that is drawn in a doctor's mind about the unique situation in front of her or him regarding that patient. Hormone therapy is complicated and not easy. It might seem easy on the surface, but in order to manage hormones with excellent outcomes and minimal to no side effects, it takes a lot of work and effort and time, not just on the part of the managing provider, but as well as the same time, effort on the part of the patient, plus the financial cost, okay, of the woman that is seeking or undergoing the hormone therapy. And in my mind, even when you think you found your groove and you're just going to cruise there at that dose with that therapy, it's not simple at all because you still need the doctor who's managing your hormones to responsibly look at your overall health and wellness. How is this therapy impacting your cholesterol levels? How is this therapy impacting your liver? What about your testosterone or estrogen metabolites? What about your cancer risk? How much of your testosterone is converting to the dihydrotestosterone? How much is converting to estrone? Is your body processing the estrogen into favorable metabolites or unfavorable one? How is this hormone therapy impacting your breast health and your uterine health? Again, let me approach the finale of this podcast episode by just giving you a few of my personal pearls of management for testosterone therapy. A testosterone level under 30 is likely too low. A natural physiological testosterone level of over 90 to 100 is likely too high. So we're talking about natural testosterone here, not therapy. If you have too much testosterone over 100, most likely it's an androgen testosterone secreting tumor, can be either on the ovary or on your adrenal. It's not like, oh my God, where is all this testosterone coming from? We need to know, okay? Now, when we replace testosterone, if we're looking at testosterone levels, a level under 70 is likely too low. I believe that over 250, with a very few exceptions, is likely to be too high, especially if sustained over a period of many years. Another pearl is when you test testosterone levels, it has to be in reference to the time of exposure to the testosterone therapy. What I mean by that is that you use a testosterone cream, you will see a big surge in your levels that would last a few hours, and please know that your body will quickly squirrel it away within your tissues, not allowing it to circulate steadily and consistently, which is what your brain, your muscle, your bone likely need for maximum impact. So when you do testosterone daily topical cream application, you will need to test at 12 hours or 8 hours after application, which can give you an idea of how long is this exposure going to last in your body from the daily cream. You test at 8 hours, your testosterone level is 50. You're like, okay, I'm probably going to be done in a few more hours, right? It is not uncommon to test testosterone levels a few hours after applying the cream in the morning and detect super high levels in the range of 400. And then you test the same day, 6 hours later. Now the testosterone is dropped back to under 50. It is the nature of the bioavailability of the testosterone cream. So be sure that you test at the right time. Otherwise, your primary care doctor who doesn't know anything about hormones is going to freak out. Okay? Testing your testosterone levels the next day in the morning without using the testosterone cream will just tell you how low your testosterone level gets back to baseline before you put the cream again. It doesn't really tell you how effective the testosterone therapy is. So always consider bioavailability of the method for the testosterone replacement that is being used as to when your levels are being checked. So when you consider testing testosterone levels and your own testosterone therapy, look at the perspective of when testosterone was administered, what type of testosterone was administered, how long was that testosterone product expected to last as a circulating testosterone within your bloodstream, and is your doctor looking at the peak of that hormone therapy, or is your doctor testing for safety? When I mention safety, I mean, do we need to know that you're back to baseline before another testosterone dose is being administered? That's what I mean by safety, right? So you can see how designing and carrying through a testosterone hormone therapy study would be very complicated, if not impossible, because there's so many ways of introducing testosterone into the woman's body. You can do testosterone drops, sublingually. I'm not a fan of those, in the form of a testosterone cream administered daily, or in the form of testosterone injections administered every 3 to 4 days or weekly, or a testosterone pellet. A study that would look at all these 4 bioavailable delivery methods of testosterone therapy for women would likely not be feasible or extremely costly to perform. There's definitely a huge lack of sponsor for such a study, especially since all the testosterone products available out there are not FDA approved. They're all compounded products coming from compounding pharmacies. So who is going to do all this research and pay for it? No one. Testosterone therapy for women, again, is not standard of care unless it is for hypoactive sexual disorder. So if you're wondering, oh, is my therapy FDA approved? No, it's not. And I've already told you my opinion about being approved for sexual desire, right? Testosterone therapy is highly valuable for women that suffer from depression, irritability, chronic fatigue, loss of stamina and endurance, frailty syndrome, osteoporosis, endometriosis, chronic migraines, low sexual desire, and so much more. I honestly believe we are depriving women of a very valuable hormone therapy that could significantly and positively impact their health, their mood, and their vitality because we're ignoring testosterone therapy in women. But this is what's happening out there. Complete ignorance. You find a physician that specializes in hormone therapy for women, including testosterone. Well, guess what? Do not expect your insurance to cover any of the products, and do not necessarily expect that physician to want to run your visits through the insurance. Most of such physicians are simply cash pay. So expect to pay out of pocket. However, the word is out there about testosterone therapy. The cat's out of the bag. Many women are now becoming aware by word of mouth of how valuable testosterone could be for them. They have a friend, a relative, a colleague at work who suddenly is smiling and happy, is in better shape, is so full of energy, and she looks so much younger. So there are women who are asking, what are you doing? Please tell me what's your secret. I need a little bit of that too. Whatever's going on that you got going on, I want some of that, please. And women talk to each other and they will happily point you in the direction of the person that helped them. Don't necessarily expect your friend to tell you what they're doing, but they might be sending you to someone who helped them. So they might just give you a name. Now, I've had a lot of women come to me referred by other women for this specific reason, because those women feel and look so much better that the people around them ask them, what in God's name are you doing? And can I do it too? How did you change so much? And when the referral arrives in the office, they're pretty much asking, hey, can I get the same thing my friend so-and-so got? Of course, the question I ask is, did they tell you what they got? And sometimes they say, yeah, they got that therapy and I want that same therapy. I don't want to talk about anything else. But sometimes they say, no, I don't really know what she did or what she got. She just told me I need to come see you. They just said you could help me. And again, even if a woman comes to me asking for a specific therapy, I still have to do a complete evaluation, take a history, listen to all the signs and symptoms, do a exam, order comprehensive blood testing, counsel them over the pros and cons, possible side effects and options of hormones. Then, believe it or not, I refer them to my podcast. There's a lot of information here. I don't have time to put it all in 1 hour, right? There's a lot of information. And then they come back, we formulate a treatment plan. Now, sometimes patients come in and they're absolutely gung-ho about wanting a specific hormone or a specific type of hormone therapy. Sometimes I don't even have the chance to go through all the options available when I do my counseling because they're jumping straight ahead. They don't want to listen to everything I have to say. Simply, they ask, hey, my friend so-and-so just got that injection pellet thingy. Can I get it too? Am I a candidate? And sometimes they come in and they say, you know what? They got that injection, but that scares me. Can I just get something else? Is that going to work for me? So, and there are others who just leave it up to the doctor to decide or advise them what is best for them. In which case, it's always good. Just dip your toe in the water, start a little cream, start a little injection, see how that works, switch if it doesn't work, and eventually you can try the next option if none of these work. So again, the point is more and more women are developing hormone awareness. It's back to the top of mind, as it should be, because we do not develop into the human beings that we are today without our sex hormones. Our sex hormones are crucial for our development and for our transformation into the women that we are today. Now, I really hope that you are one of my faithful listeners and you're getting the message about how important testosterone is for a woman's wellness and how much healthier and happier and stronger women could be if they would choose to try testosterone hormone therapy after menopause, or especially while going through perimenopause and the menopause 1 year of no periods. Now, does this mean that every single woman out there is a good candidate for testosterone replacement therapy? No, not necessarily. Do I pretend that testosterone therapy has no side effects? Not at all. Is testosterone therapy dangerous? Not if optimal levels are respected, and even though we are aiming for what we call supraphysiologic levels, we need to keep them long-term under 200 to ensure safety. Is testosterone therapy dangerous for women if the levels are consistently over 300? I know a lot of men that are coming in to get treated and their testosterone is 300. So unless you're in the process of gender transformation and transitioning, I don't think you should have testosterone that's over 300 all the time. This is something a couple of physicians disagree. There are some proponents and advocates of extremely high testosterone in women, but in my opinion, very, very, very few women benefit from such high levels. So come back next week. I will tackle estrogen, optimal versus normal. What are we looking for in estrogen replacement therapy? What are some pearls about that? What are the best levels? We'll provide the answer for that question and much more in the next episodes. Thank you for trusting me with your time, and thank you for listening to today's episode. If the content I provided wowed you, was helpful and valuable to either you or someone close to you, please do me a favor and leave me a review. I am very open and welcome any kind of feedback as well as suggestions on any content ideas, so please forward those suggestions to Jessica, my patient care coordinator, through our website, herabeautyandwellness.com. And I look forward to our time together next episode.